Hello, everybody. This is Jim Guerra. This is our BPCI Advanced Information Opportunity webinar that we're going to be doing on Thursday, February 8th. This is our truncated and quick version for recording. Glad to have everybody listening to this. Jerry and I both presented on this webinar on the 8th. Just myself will be speaking right now. Real quick, want to kind of cover some things on bundled payments, BPCI Advanced, and the like. Why are we even doing this? Why is CMS supporting bundled payments? Why is this such an interesting program for them? It's been because it's been a really successful program. BPCI Classic had 3 to 5 times the returns that the ACO and shared savings models have had. It appears to be a really successful program from CMS at this point. And the reasons that they list for their participation here are care redesign, encouraging providers to re-engineer the way they deliver care across a larger continuum, data analysis, really driving down cost of unnecessary costs or low value costs through better coordination, creating financial accountability across the entire continuum. So putting a provider such as a physician group in charge of the financial outcomes of those patients over a larger continuum. Creating more provider engagement. CMS is certainly very interested in these programs like ACOs and especially bundled payments because it is pushing primary care and specialists together, hospitals and physicians together to have to work together in collaboration and coordination. And finally, patient and caregiver engagement, the idea of engaging them more actively in their overall health, especially with additional education and more communication. As you can see, any one of the CMS officials from early on, even from Bush's administration to Obama and now to Trump's administration, there's been a lot of support around bundled payments. And so you can see the quote here from the current CMS administrator. Here's some of the key deadlines that are and dates that are really key to BPCI Advanced. Obviously, the first one, March 12th, is when the application portal closes. That is open presently, which means that ourselves, Fusion 5, as a convener, can submit our application along with every other organization that wants to participate. Real quick note, no one is currently a convener in BPCI Advanced. Everyone has to apply, so you're basically starting on the same at the same level. Everybody's applying to participate, including all the episode initiators. CMS will release target prices and data sets in May. We expect to receive participation agreements in sometime towards June, and which means that in July, you'll be making the decision of whether or not you want to move forward in BPCI. We have to, on August 1st, submit every signed participation agreement to CMS with those organizations that are going to go live and the episodes they've selected. Go live model starts October 1st. So the foundation on BPCI, we're trying to cover a couple things. One, those who are new to BPCI and bundled payments, and those who have a little bit more experience and knowledge about the program. Again, BPCI Foundation, this is a program that was, this is an initiative really that was put together by the Centers for Medicare and Medicaid Innovation Center. So the same division of CMS that runs the ACOs, the shared savings models, the oncology care model, the first BPCI Classic is the same one that's initiating BPCI Advanced. It's really a method in which all of these different payments from hospitals to SNFs to therapy to the surgeon fees are all coordinated and linked together in one payment for a 90-day period of time. It is a fee-for-service program only, so this does not include any of your Medicare Advantage patients, any of your TRICARE or veteran patients. This is only your straight Medicare fee-for-service patients. It's pretty simple how they do this. Medicare comes up with the target price. I'll speak about that shortly. And that target price, they aggregate the target price times the number of episodes and then the actual cost of those episodes. If you're below that target price, then CMS will pay to the convener or episode initiator the difference. If you're above the target price, then the convener or episode initiator then pays the CMS that difference. So other key parts of this, the foundation of bundle payments, it's an episode of care that includes financial and clinical outcomes. So quality measures are linked to the financial payment. They're not separated. Physician groups and hospitals in BPCI Advance can participate as episode initiators and or conveners. Skilled nursing and home health agencies unable to participate directly as episode initiators, but physician groups and hospitals can. This is an advanced APM, so if you want to qualify for MACRA, BPCI Advanced allows you that opportunity. It is a retrospective program, so your billing and collections does not change. So this is not going to affect anyone in your revenue cycle department. This is a retrospective program. You bill and collect with Medicare just as you normally do. Go live date, October 1st of this year. And we will, as part of the application process, Fusion 5 will be providing, providing to all the groups a PGP list and a participation list. These are the actual documents that come from CMS, which are what we need completed and filled out and which we submit to CMS. It's key to have these documents be accurate so that you have your right and correct tax ID along with having the correct physicians listed. It's what helps us and CMS establish your target prices and also address who is the episode initiator. So what determines an episode? What's actually in this episode? So they're DRG based. So these do not include a lot of outpatient episodes. There's really only 3. This does not include any outpatient joints for orthopedics. This is really about inpatient joints only. What happens, what determines the bundle is a DRG is billed for that patient at a particular hospital. In the UB04, the billing document that is filled out by the hospital, there is an attending and an operating field in that. Your physician has his MPI listed in that field. CMS looks at DRG 470 is billed. Physician's MPI is here. That physician's MPI is linked to a TIN that is participating in BPCI, and boom, that patient is now listed as being part of the bundle. Duration includes 72 hours prior to surgery, the acute services inside the hospital, and then 90 days after the patient is discharged. Gives you roughly 92 to 96 days that typically the patient's in this bundle. Who are the participants? What are the key participants? Well, really, they're designated by CMS in 3 categories: convener, non-convener, episode initiator. Who's a convener and what would a convener be? So Fusion 5, we're a convener. We'll be participating as a convener and representing other episode initiators. So it's an organization, it's a participant that brings together episode initiators to facilitate coordination, assume portions of risk and reward. So if you were interested in being your own convener as a provider group, as a physician group, why would you actually decide to convene? Well, there's 3 primary reasons. 1, just simply control. You just want to have the contract between you and CMS. Number 2, growth. You're a group that is expecting to have another 1 or 2 groups merge, and so prior to the merger, you'd like to convene for those 2 or 3 other groups. And then finally, alignment, right? So one of the main reasons we've heard back from organizations of an interest of convening is that they're in a market in which they work with 5 other physician groups, 5 other orthopedic practices, that they're not interested in becoming 110. They're not interested in being a single tax ID for all of them. However, they are interested in working together, and the idea of establishing a convening company and then that company convening for the other these other physician groups is really attractive to those organizations strategically within their marketplace. So these are some of the reasons that you'd convene. Quick note, if you are a physician group that is convening, you are also an episode initiator. So you're an episode initiator and a convener at the same time if you convene. If you'd elect to choose Fusion 5 as your convener, then we would convene and you would act as the episode initiator. Non-convener, what's a non-convener? It's really just one single tax ID for a physician group that wants to only participate for that TIN and that TIN alone. Some larger groups may select that option. It's not typically used. Episode initiator is any provider or participant who participates with a convener to bear risk or reward. So the majority of you, if you're convening or you're participating with a convener, you will be an episode initiator. So who can get into BPCI Advance? Who can actually participate? So physician groups and hospitals, they can act as episode initiators. They're the only ones that can be episode initiators. But they can also act as conveners or non-conveners. Third parties, like Fusion 5, can only participate as third-party conveners. We're not episode initiators, we're only convening. Which patients are included? Essentially, the simple thing in BPCI with Medicare is think everybody's included. So every patient that has a DRG that's billed under 470 or 469, if you put lower joints into your bundle, every one of those patients is included. That's the easiest way to think about it. There is some exclusionary criteria, but it's just easiest to think they're all in. Who's being excluded is going to be CJR mandatory markets or those voluntary markets in which the hospital is elected to remain in CJR. There's still some questions around that, and I certainly know that there are a lot of groups pushing AOS to try to get get CMS to allow groups that have been in BPCI Classic to continue to be grandfathered into BPCI Advanced and not have the CJR rules applied to them. Other exclusion criteria could be clinical, the clinical exclusion criteria that's provided, but more importantly, some of the areas where you have a next-gen ACO, you have a Medicare Shared Savings Program that's in Track 3, the Vermont ACO, or the ESRD organizations. So what are the incentives inside of BPCI Advanced? What's the financial outcome? There's two types of revenue streams for any physician group that is participating in BPCI Advanced as an episode initiator. One is reconciliation. This is the net payment reconciliation amount. In Advanced, it is a semi-annual reconciliation. This is the difference between the target price and the actual cost of doing those procedures. So this is essentially revenue, the money that is paid by CMS. If you're an episode initiator, CMS looks at the data, says, oh, you saved $100,000. They pay that to the convener, and the convener pays that down to the episode initiator. The second revenue stream or opportunity is a gain share, and the gain share is commonly referred to as internal cost savings. Now, it is possible to gain share both ICS and NIPRA at the same time, but typically the gain share arrangements look like this. A hospital physician group enter into a legal gain share arrangement. We're still waiting from CMS to have waivers on Stark, any kickback, and civil monetary penalties. Fully expect that to occur before October, since CMS has already submitted to OIG for those waivers. They're similar to the waivers that were applied in BPCI Classic. So this legal gain share arrangement occurs between the hospital and the physicians, and the internal cost savings are created by reducing implant costs, supply costs, or any other hospital-related costs that can be tracked and measured. Where does that revenue come from? If there's a cost reduction, it comes from the hospital. So the benefit to the hospital is that they've reduced cost overall, and because of that cost reduction, they're able to pay to the physician group out a portion of internal cost savings. That is capped at 50% of the physician's fee schedule. Gain sharing participation, NIPRA gain sharing and risk sharing. one thing I want to point out is not all of the criteria has been released by CMS. Each week, more information seems to trickle out of CMS, so we will know more as time goes on, especially to particular rules and what governs certain aspects of the program. So right now, this is, to the best of our knowledge, what we know about the gain sharing participation opportunities. One, gain sharing, risk sharing on NIPRA. This is the cost reductions to CMS, typically shared between a convener and episode initiators or other downstream partners. Potentially could be risk sharing arrangements that you enter into with your post-acute care facility, such as a SNF or home health agency. There's a risk component, obviously has upside and downside. The ICS gain sharing, CMS has hinted at this. We believe it's going to be similar to what their previous arrangements have been. This is applied to direct costs incurred within those facilities, typically implants and supply costs. Typical gain share arrangements are done between hospitals and physicians. Again, physicians are capped at 50% above their fee schedule, so if a doctor collected $10,000 for his fees and he had saved $7,000, the most he can get is $5,000, so 50% of their fee schedule. We expect waivers on anti-kickback, START, and CMP. There's no risk component in this arrangement. This is simply a direct cost reduction to a particular provider. So what are some of the differences and highlights between BPCI Classic and Advanced? If you've been in Classic, you remember that Classic was not an approved Advanced APM model. BPCI Advanced is an approved Advanced APM model, so if you want a opportunity to qualify for MACRA, BPCI Advanced gives you that opportunity. Both programs are voluntary. Some other key parts of the differences, BPCI Advanced is only one model. They're only testing one model. It's the same model. It includes the DRG, the inpatient portion, and the post-acute care portion for 90-day episode, regardless of clinical episode. Classic included 4 different types of models. So there was some that included the hospital, some that didn't include the hospital. There's less episodes within Advanced than there was in Classic, and the episode length is still 90 days for everything in Advanced, whereas in Classic you had 30, 60, and 90 days. Other key part is obviously the Advanced APM criteria that BPCI Advanced provides. Some of the other key things, and this is taken from CMS's information, so you can find this easily within their site. One of the other key parts, and we still don't know the rules or the impact that will occur on the data, is hospice care is included in Advanced BPCI. This is likely to be most impactful on those cases that are trauma cases. So this may affect those patients or those cost areas. We really don't know yet until we actually receive the data from CMS sometime in May to get an idea of what's hospice impact, what is it going to be. So exclusion criteria, relatively similar. There's some additional amounts that are put into there. Readmissions, some differences, not a ton. Episode initiators, obviously they've reduced the number of episode initiators just down the hospitals and physician groups. Again, they continue to be retrospective reconciliation processes. There's quality measures. I will speak about them shortly, but there are quality measures in this program. In addition, there's been some questions we've received on the stop loss gains. I think the simple thing to look on the stop loss gain is in every scenario that we have ever run on our data right now, it is highly unlikely that any organization is going to hit either one of those stop loss. 20% is a pretty significant amount for any organization to hit. So we expect that to be unlikely to hit any of those. It's really more of a run-rate train avoidance. Quality measure, again, that you've qualified for Advanced APMs. One of the key things in CMS are going to be these waivers and incentives, very similar to what they have previously used, which is, you're able to use a telehealth waiver, post-discharge home visit waiver, but most importantly, your beneficiary incentive waiver list. So in BPCI Classic, each organization that was a convener was required to provide what was called an implementation protocol, which outlined basically the operations of the program. They're extraordinarily lengthy documents. It's like a full-on operating model for BPCI. Inside of that is an area called the beneficiary incentive waivers, which the convener and/or episode initiator apply to CMS to have a beneficiary incentive waiver approved. These could be things like transportation. It would instead of a patient going to skilled nursing, which can cost $450 a day, that patient could go home. However, they need to have somebody drive them to their visits, either with physical therapy or to see the doctor. It's cheaper to pay the $50, and that would come out of the provider's pocket, to pay the $50 to cover transportation than it is to have the patient go to a skilled nursing facility for $450 a day. So you can get beneficiary incentive waivers on transportation, Meals on Wheels, assisted living, some other therapies and such. So on the BPCI quality measures, this is what helps qualify this program as an advanced APM. One, the quality measures will be scored and they will account for 10% of your reconciliation net performance. So if you saved $100,000 and you did not meet any of your quality measures, you would get $90,000. So it would be, there's 10% of your savings is essentially at risk of not being fully paid because you've not met all those quality measures. They're scored for each measure by episode and then aggregated up across all episodes per episode initiator. It is a composite quality score that is weighted for the outcome measures and will adjust obviously during the net payment reconciliation period. We don't have all the measures yet, nor do we have the target pricing methodology for us to apply prospective CQS scores to the impact of what potential NIPRA could be. CMS collects the data from the claims, so this is not data that you have to collect or we have to collect. It's data that presently comes from claims data. CMS is reserving the right to add additional quality measures in 2020. These are likely going to require certain tracking and collection. There's been, for a fairly lengthy period of time, there's been a lot of discussion on which quality measures should be tracked or applied to the different clinical episodes. So we'll expect to hear something about those potential quality measures in probably mid-year of 2019. Here are some of the quality measures. Again, this is on the CMS BPCI Advanced website, so you can pull any of this information down. Obviously, number 4 for any of those particular orthopedic groups that are going to be involved in this is going to be a key quality measure. And again, we don't have the weighting yet. We don't have how they're going to rank the composite quality scores as of yet. What's the impact on MIPS and macro for any groups choosing to be in BPCI Advanced? Again, this is an advanced APM, so you qualify. You may qualify for the 5% lump sum bonus for macro. The other advantage is you're likely to avoid the MIPS upside downside impact. We're still awaiting CMS final rules and information on the direct impact of macro, and really covering a few questions we've received fairly frequently, which are, do physician groups need to assume downside risk and how much? To qualify for MACRA, there must be some assumption of downside risk. So it appears that the physician group must accept that. We do not know if that will be in the form of a set amount from CMS. To give you an idea of what that could be, CMS established a criteria in BPCI Classic called the secondary repayment source amount. It was an amount that was calculated per group, and that it was not a significant amount of dollars, all things considered. It was based on, your the number of episodes and the cost of those episodes. So it could be as low as 10, 20, 50,000, but it easily could be a couple $100,000. But really relative to the size of your organization. Will BPCI Advance provide enough volume to meet minimum macro requirements? That's an individual question, so it's really going to depend on your payer mix and us helping you do an analysis if you're not able to determine what the impact could potentially be. And finally, probably the number one question I've gotten is, do physician groups still need to collect and report MIPS? I hate to tell you this, but it appears right now that you need to continue to collect MIPS. The question with that is that, do you need to do a good job of collecting it? Can you do a pretty poor job, since if you qualify for MACRA, if you're not going to be penalized for MIPS because your MACRA qualification, do you really need to do a good job of it? Really not exactly sure yet if there's any penalty related to poor collection and reporting. Key discussion in this, target price. So we have as yet to receive the target prices from CMS. That occurs in May. It will be based on historical hospital costs from 13 through 16. So this is not cost that is just applicable to the orthopedic group or the physician group. It's for a hospital cost. CMS will establish a hospital benchmark. That hospital benchmark is based on historical costs. So if you're the only physician group at the hospitals in your market, it is going to likely marry up to your historical costs. But if you're the physician group and there are other groups within that market, you're likely going to get the benefit of those other groups potentially contributing to higher overall costs. You'll receive a benchmark for the hospital. There'll be a case mix adjustment to the hospital. So if you go, if 50% of your patients are at hospital B and 20% at hospital, or 50% are at hospital A, 20% are at hospital B, and 30% at hospital C, they'll apply that case mix adjustment to those different hospital targets. And the reasoning being is that if hospital B is $1,000 less, CMS doesn't want to see you just game the system by shifting all your patients from hospitals A and C over to B to just create an instantaneous $1,000 savings. There's a PGP efficiency factor. We have no idea what that means, other than there's going to be some factor indicating how much more efficient you have been. This really could be interpreted a number of ways, good or bad. There's a patient case mix adjustment. CMS is going to use a risk adjustment on patients. So if you have a riskier patient population and that is appropriately documented, it is likely going to be in your favor to increase the potential cost of those patients. We also have a regional trend factor that will be applied that is based on similar to CJR, that's based on census tract. So we expect to have a regional adjustment at the same time. CMS is going to take a 3% discount, so they'll come to the benchmark and take a 3% discount, and that essentially is your target price. So benchmark times 1 minus the 3% discount. The key thing here, and this is really important when you're considering you were in BPCI Classic and you had challenges with target pricing that changed over time and made you either lose money or have to exit the program. The key difference in Advanced is this: it's prospective target prices. So the target prices you receive in May are the target prices that will be held steady through Q4 of 18 and into 2019. If there's a case mix adjustment, yeah, or you move patients from one hospital, you're going to see an adjustment there. But you're not going to see readjustments based on benchmark or efficiency factors. So you're going to know your target price going in, so you would know, okay, we've got a pretty good chance of doing really well in this program. We're not sure, it's a 50-50, or boy, this program looks terrible, we can't get our costs below this target price. So you'll know that before entering into BPCI now, and your continuation each year. So if the target prices are good when they come out in May, you say, hey, we're going forward. You do the first 15 months. Well, in 2019, you're going to receive target prices for 2020. And if you see those target prices and they don't look good, you can exit the program before the end of 19. What do you have to do now? So the application to participate, the deadline's March 12th. That's when the portal closes. Ideally, we have information in before the 8th, but we have to get, you have to make a selection definitely before the 12th. You need to choose your options. You want to be an episode initiator, you need to select a convener. Are you going to self-convene, or are you going to be a non-convener? Well, you're going to have to submit an application along with a list of your episode initiators and all your physicians. Basically go through the entire convening process, application process. Selecting a convener. Another question, you can select multiple conveners. CMS doesn't regulate that you select only one during this time. You do need to select one in July before you go live in August, or before you submit in August, but right now you don't have to select a convener. We would suggest you select for success, not necessarily based on, hey, we're not sure what we're going to do and who's going to take the most risk. You really want to select based on, hey, how well can we do in this? What will we learn? How much better can we get? And part of that success is financial, but it's also how do you really make improvements as an organization? What would we need at Fusion 5 to submit for you? Jerry Rupp has sent out to everybody a participant list. It's an Excel workbook that has a participant list and has a PGP or physician list. We would need both of those completed. Should take you about 30 minutes, maybe an hour at best, to help complete. We've pre-populated a lot of that information that we have to make that a little bit easier, but we would just need that back from you, and then we'd be able to submit. You don't need to fill anything out on the application. You don't need to answer any of the questions on the application. If you fill out that Excel workbook, we're basically good to go. Key dates again, ideally you've selected your convener by March 8th or a couple conveners by then. Target prices in May. Participation agreement, you have to elect to participate really in July, because on August 1st, every convener is submitting their participant profile. You start October 1st. The next time you can enter or withdraw either yourself and or episodes is January 1st of 2020. So why would you consider doing BPCI Advanced if you've never been involved in this before? Well, Medicare and payers are transitioning to value-based care payments, so you're hearing more and more about bundled payments. This really is the wave of the future, so better to get in early, learn, and make the adjustments and get yourself prepared for these changes. There's huge rewards. If you do this right and you've selected the right convener and the right management folks who know how to run these programs and provide the support to make you successful, you can do really, really well in this. It can be a really good financial win for your organization. In addition, you qualify for MACRA. Maybe it takes the pain MIPS away, and that 5% bump could be pretty noticeable for you. You receive invaluable analysis of your Medicare data and a better understanding of your opportunities, performance. That at a minimum, even if you're thinking, hey, we don't know if we have the capabilities, we don't know if we can do this, we're not interested, you should at least sign up with a convener in order to get your information, your data. Fusion 5 has immensely powerful data capabilities. And so our ability to give you a snapshot and understanding of what this opportunity can mean now and in the future is fairly significant. So you really should sign up for that purpose at least. And again, signing up right now before March 12th, there's no risk, no commitment. You're considering whether or not to participate. So how do you succeed in BPCI Advanced? How do you create $1,500 to $3,000 of savings per episode? Well, based on our experience in this program and in numerous other programs that we've worked in, you have to align with experience. The folks that understand, how this program works, the ins and outs of the rules and the regulations, and really what are the operational support that's needed to be successful in this. Build a comprehensive program. That's a program that allows you to manage the post-acute care network, the SNFs, the home health, the outpatient therapy, the inpatient rehab places, but also allows you to redesign care in a way that has an impact on improving clinical management across that entire continuum of care. Select episodes which are right for the opportunity, that have a good target price. Select those that you can have an impact on. Doesn't always necessarily mean you pick the high benchmark, but you pick the one where you have the most ability to impact. You need intelligent and actionable analytics. You need data that tells you, okay, what's going on, what do I need to do, and then what's the action plan to do it. And you need an organization, a convener that can then help you translate that and put those action plans together and help you put those ideas and thoughts into actions. Developing a high-performing post-acute care network. It's a reason that Fusion 5 has brought on a substantial team of post-acute care experts who have experience in SNF, home health in these areas, and in BPCI, is because a really high-performing post-acute care network can yield enormous dividends and value to you and BPCI and to your patients. And then having the right care management and clinical support solutions and tools, both technology and people, that help support your organization's ability to be successful in this program. So why would you pick us? What makes us different? We have an experienced team, history of working in these types of programs very successfully, and really BPCI, ACOs, a lot of Medicare Advantage experience, areas that are above and beyond just bundles. We've been very successful in models that have been replicable and scalable, but at the same time, very tailored and customized for your local market. Management teams made up of a bunch of innovators who have significant influence at CMS and have developed really deep relationships with those folks to the point that we have actually engaged with and helped craft some of the regulations, policies, or interpretations of some of these programs. We are Fusion 5 is a preferred partner with the Ortho Forum and Ortho Connect, so you're going to get the best pricing from us. We proposed a great pricing option to begin with, and we continue to respond to the requests and needs of the Ortho Forum and Connect members to address a pricing model that will help make them successful. And I'll talk a little bit about our new pricing models, which will be very responsive. We have a transparent and open data analytics platform, so you're going to know what's going on all the time, right? You're going to know how well you're doing, and you're going to know how well the others in your market or in the Ortho Forum and Connect are actually performing. And finally, we have options beyond BPCI. So we're not just solely focused on BPCI. We have a group of executives who've held senior level positions at Aetna, Blue Cross, United Healthcare, Amerigroup, a variety of places who have experience in commercial bundles, case rates, Medicare risk programs, Medicaid, a variety of areas in which we can bring a full solution experience to help you, for your particular market, address other value-based care opportunities beyond BPCI Advanced. So some of the Fusion 5 options, the fee structure, I think everybody's seen this. We're going to be continuing to update and send out. We have a simple admin tier that you can select. So you can select either the admin tier, which sets a flat rate. Those are for the groups that typically have more experience. Or if you're new to the program, don't really know what's going to be going on, we have a shared savings model in which we'll take a significant portion of the downside, which could be all of it, with the caveat that CMS may not allow that, and/or you may want to take some downside to qualify for MACRA, with an upside split of 75% going to the group, to the orthopedic group, and 25% staying with Fusion 5. So pretty significant incentive for you guys. We're flexible, so if you want to start off, if you want to act as your own convener, that's fine with us. We're happy to white label that option for you, so provide the services and you're the convener. Or if you want to start off as an episode initiator and we're the convener, happy to do that at the same time. That flexibility stays with our fee structure. So we may enter into a shared savings program with you at the beginning, and as you improve and get better and stabilize your cost, you get to a point where you say, you know, hey, you guys are making a lot off the 25% upside. Why don't we split this? Why don't we flip to an admin tier? We're happy to do that. The other option is we're a partnership. We're more than just being a convener for you in BPCI Advanced. Lots of experience, lots of knowledge in this area, but we're going to certainly be focused on BPCI Advanced. But we have other value-based care options for commercial bundles and other opportunities we can help you explore. And finally, and you'll hear about this throughout the next few days, few weeks, and months, is our proposed joint venture with the Ortho Forum and Ortho Connect to do the Ortho Data Exchange opportunity, which will open a transparent platform and really allow the members to basically become leaders in the new era of orthopedics. So the next steps here, we've done an analytics demo that has been recorded. Everyone will have access to. We have sent out to everybody the PGP and participation list. It takes about 30 minutes to an hour to complete. Feel free to contact any of us if you need help completing that or have questions. And then finally, look forward to setting up some face-to-face meetings with any of the folks attending the Ortho Forum meeting or after the forum meetings, and then look forward to meeting everybody with Ortho Connect in the May meeting, or hopefully before if we have a chance to come out to your city and meet with you. That's it. That's it for our webinar. Thanks everybody for attending, and this will be the recording that will be available to everyone.